this topic is, I think, very important because it is, this topic is about the difference between mechanical implant and visco-elastic disc implant. And now, as we have follow-up from 2005 for lumbar spine and 2012 for cervical spine, we have a lot of data regarding the biomechanical characteristic. So I shall speak about what I know, lumbar ESP on the left and cervical ESP on the right. Marc-Antoine explained very well the difference between those two implants, and you have here the type of construct of the lumbar and the cervical disc. You see they have limiters and they have very special cushion, different for lumbar and cervical implants. But when we speak about cervical and lumbar disc, when we speak about cervical and lumbar disc, we have in fact to look at the sagittal plane and to look at the range of motion and the mean center of rotation. What does it mean for range of motion? It is sagittal rotation, and it is it has been very well developed for mechanical implant. We have also translation, and we don't have a lot of data about this phenomenon of translation. And what is very important for me, it is the mean center of rotation. For cervical disc and for lumbar disc, it is the same topic. So when we speak about cervical disc, we use as a reference young asymptomatic cases. And I think it is dangerous because when you look at the vertebral rotation, the aim could be considered to be 15 degrees angular rotation for flexion extension. Regarding translation, it is more reasonable to speak about 2 or 2.5 millimeter for translation. But if we look at the population of the patient we operate, you see that the range of mobility which is expected is much less. In this small graphic taken from 200 cases, you see that the mobility, the range of angular motion for C5, C6, C6, C7, which are the level most operated in our experience, is much less than what is expected for young asymptomatic cases. So when we speak about range of motion, we are able to analyze the different level. Here you have C3, C4, C4, C5, C5, C6, for example, for a C5, C6 ESP, and C6, C7. And you have here the range between 12 and 5 degrees. You can say to me, this slide is too busy. So I look only at the 6.5 C6 ESP. And you see that when you look at the follow-up for 1 year and 2 years for a monosegmental implantation, we are in the range of what is expected in the population we generally operate. Same thing for C6, C7. You see all of the level in our implanted cases and the range 12 to 5 degrees. And you see, I suppress the busy part of the slide, you see we are again in the range a little bit more mobile than what is expected for this population. Regarding translation, you see on this graph, I hope the video will work, but I'm not sure. You see on this graph that the range of translation is about 2 millimeters for C6, C7, and a little bit more for C5, C6. What about the limitation of translation? You know that we have a limiter inside of the CP-ESP. It explains the limitation of translation. But, and I hope the video will work, it does not work, if you flex CP-ESP, in some cases, you have, of course, the ideal scenario. You have here the translation. And in some cases, you have this. You see this on this model, on this reconstruction, you have rotation. So when we analyze the translation on our lateral view, we have some parasitic effect, which makes those measurements more complex. So what is important is to look at the mean center of rotation, which is the combination of this rotation and translation. All of us, we are accustomed to look at the mean center of rotation as on the right of the slide. And we don't speak a lot about the instantaneous center of rotation. Most of the time, we analyze the global view regarding the center of rotation. And we know, as it has been published, that if we have more flexion, the center of rotation is higher. And if we have more translation, the center of rotation is lower. That's the reason why we put a lot of importance on the location of the center of rotation. Now, if we look at the degeneration of those patients, the degeneration of the patient we operate, you see the center of rotation is not the ideal center of rotation we have in young, sexy, asymptomatic patients. When we move from C3, C4, of course, we have center of rotation higher, but we have a cloud of center of rotation higher and higher with the age and with degeneration. So when we want to analyze our center of rotation, we must take care of this value of degenerative center of rotation as published in the literature. Now, our cases. We know that we can analyze the center of rotation regarding x-axis or y-axis. This slide just only to show you that we are able to calculate the center of rotation of the other vertebra. It is interesting that I have no time to show the evolution of the center of rotation. It will be another topic. I make the slide less busy, and you see between 12 months and 24 months, you see the evolution of the center of rotation moving a little bit higher than the normal population because we have more flexion than normal population. So adaptation of the center of rotation. This is the case for monosegmental implantation, C5, C6. What about C6, C7? You have all of the cases, all of the level. I make the slide less busy, and you see again that there is an adaptation of the center of rotation moving lower because of the adaptation with translation. So the big message at this stage for cervical disc is, of course, we have rotation, we have translation, but what is very interesting is to see the adaptation of the center of rotation with the time. You can say to me, okay, it is the case for cervical disc. What about lumbar disc? I have a few minutes now, but I want to share with you this very interesting paper from Wu, exploring the impact of proximodistal translation and AP translation when moving the spine from flexion to extension, the normal life. And we see that L5S1 is the level with the more importance of translation in the proximodistal direction, more compression. On the contrary, L4, L5 is the level of AP translation. So with the same implant, we must solve two different problems, compression and translation. And you see intuitively the interest of visco-elastic implant. Okay, you can say to me, it's theory. What about your true life with your implants? I shall answer, mean center of rotation is a key point. I want to share with you this publication of Tournier looking at the mean center of rotation, the cloud of mean center of rotation for L4, L5 levels and L5S1 level. You can see that for L5S1, the cloud of center of rotation is higher. In some cases of normal patient, the center of rotation is even inside of the level of the disc. You have seen that at the cervical level, we were fighting to avoid the center of rotation inside of the level of the disc, but for the lumbar level, it is not quite the same. Now, from a series we published in 2019, L4, L5 level. I can, of course, analyze the center rotation regarding Y-axis and X-axis, but I think it is more interesting to look at the cloud of center of rotation. You have here for L4, L5, you see it's quite similar for the L4, L5 level regarding the asymptomatic patient, and L5, S1 also. It is very surprising that we don't have discrepancies regarding the normal life of those patients. You can say to me, okay, it is for L5, L4, L5, the level with more mobility and the level with more translation. What about L5, S1, the level of compression? Again, you have L4, L5 non-operated level and L5, S1 operated level. And you see, you can compare, it is very intuitive. You see that the cloud of the center of rotation is quite the same. Of course, you can say to me, it's very quick presentation, but now we have the data. We have very precise data proving this. So my UMIL conclusion are, first, what are the prerequisites for optimization of this replacement? First, the reconstruction of range of motion. Segmental rotation, but segmental rotation of the patient we operate is not the segmental rotation of young, sexy, asymptomatic patient. We must also reconstruct segmental translation, but translation measurement we do are sometimes difficult for the interpretation because we have a combination of transverse rotation. Reconstruction of the mean center of rotation is something we must analyze, but not regarding roughly all of the level, but independently, level by level. And what is fascinating, I have no time to express this, is to see the adaptation of the adjacent center of rotation. And we see that by the time we have an adaptation of this center of rotation of the adjacent level. So probably a possibility, a hope of protection of those levels. But our patients have local and regional alteration. Posterior facet, Svante will speak about this, and variation of sagittal balance. How can we imagine that with the same mechanical implant, we can solve the problem of lordotic cervical spine and the 30% of kyphotic cervical spine? The same reflection regarding the lumbar level. So to date, those visco-elastic disc replacements are very forgiving for the potential adaptation for range of motion and center of rotation. Personally, I can speak mainly about monosegmental implantation, but other colleagues, Van Berg, people from Germany, from Australia, have a lot of experience with multi-level implantation and hybrid construct. So we shall discuss about this, but we must consider that this presentation is a very UMIL presentation, a very partial presentation of a very limited presentation of our result, but it can open the mind about the interest of this type of implant. Thank you.